Welcome back to Pharmacology, where we look at drugs affecting the endocrine system. We'll particularly look at the thyroid, the endocrine pancreas, and then the adrenal glands. We're particularly interested in looking at drugs that treat hyper and hypothyroid conditions. We'll look at a range of classifications for diabetes mellitus and concentrate on treatments for types 1 and 2 diabetes mellitus, though we will mention treatments in gestational diabetes. We've looked at corticosteroids as they are used in the treatment of asthma. We'll look at glucocorticoid steroid treatment in general, some of the adverse metabolic and endocrine effects, such as on the hypothalamus, pituitary, adrenal axis. We'll also look at the topical use of glucocorticosteroids so as to reduce their adverse effects. So first of all, the thyroid. You have to go back and review normal thyroid functioning. The thyroid hormones are needed for normal growth and maturation in the body. If there's an absence of thyroid hormone, this will then lead to mental and physical slowing in adults. For children, though, who are still going through neurological development, we'll see that there will be intellectual impairment and dwarfism. You have to review the system of normal negative feedback. How when there are low levels of the two thyroid hormones, T3 and T4, that this sets off a normal negative feedback system in the body that then leads to high levels of T3 and T4. The response switches off the stimulus or opposes the stimulus. So you have to review how that normal negative feedback involves the hypothalamus and the pituitary. So this is the hypothalamus, pituitary, thyroid axis. The hypothalamus produces thyrotropin-releasing hormone, TRH. TRH travels a very short way in the portal veins to the adenohypophysis, otherwise known as the anterior pituitary. It is then caused to release TSH, thyroid stimulating hormone. The thyroid stimulating hormone travels to the thyroid. It stimulates the follicular cells. These follicular cells line the colloid at the center, where T3 and T4 are stored. Eventually, they will be released into the body. They'll travel via the blood to all of the cells, and therefore they will then increase normal growth, maturation, use of oxygen in oxidative pathways, and therefore will help tissues make ATP and use ATP. So we'll see that these thyroid hormones regulate lipid and carbohydrate metabolism and also have effects on protein synthesis in most cells of the body. So T3 is triiodothyronine, T4 is thyroxine, tetraiodothyronine. When you review the physiology, note that T3 is the more active of the two thyroid hormones, and so T4 is converted into T3 by deiodinase. To be more accurate, 5-deiodinase. We'll see that there's more than one enzyme and more than one form, and T3 is the active form. So in hypo and hyperthyroidism, there is respectively underactivity of the thyroid in a hypo condition and overactivity of the thyroid in a hyperthyroid condition. Note that this is not a disease as such, where we have a distinct etiology. It is a range of common symptoms to say hypothyroidism or hyperthyroidism, so review those symptoms. What we're saying is that there are many conditions that lead to hypothyroidism, and you have to go and research some of those causes, such as an infectious thyroiditis or Hashimoto's thyroiditis, which would lead to a hypothyroid condition. And then there's Graves' disease as one example of a hyperthyroid condition. And as we said there, that hypothyroidism is one of the most common metabolic disorders, where it has a distinct female predominance. We have a ratio there, men is to women, 1 is to 6. For women over the age of 65, as many as 1 in 10 of them would have evidence of early stages of hypothyroidism, where they may show no or very few symptoms, but the symptoms will then continue as that female increases with age. We'll look first of all at hypothyroid conditions and what would the goals of treatment be in such a condition, and then look at the Western pharmaceutical medicines that will achieve those goals. So with a hypothyroid condition, important once again to get a causation. Hypothyroidism being just a collection of symptoms. Look to the cause, establish the severity of the hypothyroidism, and treat the cause. The other aim of treatment would be to restore thyroid hormones to physiological homeostatic ranges. At the very least, it would be important to provide relief from symptoms, hopefully by re-establishing normal thyroid hormone levels, and then this will help the person to regain normal physical metabolism and to restore a normal emotional state. If it's a young child or a newborn, as we said, they're going through neurological development, most important that they are identified if they have a hypothyroid condition, so as to prevent that dwarfism, to prevent any neurological deficits. So the Western pharmaceutical treatment will be to give synthetic thyroxine, T4. Even though this is not the more active of the two hormones, this is the better drug therapy. Liothyronine is a sodium salt of T3, and it is the more potent and more active form of the hormone. We'll talk about some natural therapy problems with the use of T3 as a sodium salt in just a normal oral dose, and the two formulations, one brand name Oroxin, under which thyroxine is prescribed, and tertroxin, under which liothyronine, the T3, is prescribed, some of the problems with their use. T4 is the drug of choice for just normal hormone replacement therapy for life in the case of a hypothyroid condition. Liothyronine is given where there will be an emergency. So make sure you look up some of the emergency symptoms of a hypothyroid condition, such as myxedema or a myxedemic coma. Also, liothyronine might be given for short-term use to help symptoms stabilize. Thyroxine, also sold under the brand name Utroxig, is available for hormone replacement therapy for life in cases of hypothyroidism, for replacement after thyroid block if a person is hyperthyroid. So we'll look at this thyroid block treatment shortly. If the person has a thyroiditis, we suggested it might be infectious or Hashimoto's thyroiditis. If they have a goiter or a thyroid carcinoma. So thyroxine replaces their endogenous thyroid hormone, and that thyroxine will be metabolized by that 5-deiodinase into the active form T3 in the body. Because it is taken as the T4 form And because T4 does have a long half-life of 7 days, with oral administration, it takes about a month for that person to reach a steady state concentration. However, because it is still an active hormone and it is metabolized into the active form T3, the person will show some improvement in their symptoms within 2 to 3 weeks. It is important as a natural health practitioner to be aware of when your clients are on thyroxine and to know that it is critical not to take them off doses very rapidly. They need to be teetered, that is, doses slowly reduced or slowly increased. And it's because of this long half-life. You begin to see the importance of knowing a little bit of the pharmacokinetics of some of the therapies that you'll find your clients will be on. So we've suggested that to reach a maintenance dose, a person might be started off at 100 micrograms daily, and then it would be teetered slowly to 150 micrograms so as to control symptoms. If it's an elderly client or a client with some form of ischemic heart disease, they might be started at a lower dose and built up to a lower maintenance dose of maybe only 75 micrograms, or sufficient to control their hypothyroid symptoms. When on thyroxine, it could cause very rapid heartbeats, as we will see when we study hyperthyroidism. If a person has a hypothyroid condition, then this could lead to bradycardia. While on thyroxine therapy, it's important for that person to have a yearly cardiac check. Definitely if they were elderly or had an ischemic heart disease, but for all clients. Also, if they're elderly and have a heart disease, it's important to monitor the thyroxine regularly. Even for a person who is from a different demographic in society and is on thyroxine for a hypothyroid condition, still very important that there is regular monitoring of their thyroid hormone levels as well as TSH. If the person goes into a crisis and needs to go on triiodothyronine, the sodium salt, that liothyronine, then also important then that they are monitored afterwards to see that symptoms are being appropriately controlled and that they're not at risk then of adverse effects of the hypothyroidism, such as that bradycardia, a slow heartbeat, simply due to low metabolic rate and low availability of ATP as a result. If a person is taking thyroxine at normal maintenance doses, this will lead to plasma concentrations very similar to those seen in the normal physiological circumstance, the normal levels of thyroxine. At these doses, adverse effects tend to be controlled. The person might experience insomnia from their thyroxine therapy due to that raised metabolic rate. There might also be problems with bone mineral density, but at the usual doses, the usual maintenance doses, around 150 micrograms, the effect is minimized even in premenopausal women. Thyroxine does have many drug interactions. We've listed one of the commonest drugs which interacts with a whole variety of others, and that is warfarin, but also cholestyramine, which is that bile acid binding resin that's used in treating hyperlipidemic conditions. There are a range of signs and symptoms that are very common to many metabolic disorders. The same is true with thyroid disorders and the endocrine pancreas disorders such as diabetes mellitus. In fact, thyroxine is used with caution in people with diabetes mellitus. Also, people who have an adrenocortical pituitary insufficiency, thyroxine might be used with caution in these people. Another endocrine gland with another disorder, and so thyroxine used with caution in those people. And of course, because it can lead to tachycardia, due to influences on metabolic rate and availability of ATP to cardiac muscle cells. It's used with caution in people who have an existing cardiac disease. Now, one thing you're going to come across in clinic will be people who don't actually have a diagnosis of hypothyroidism. Their doctor might have prescribed thyroxine for other reasons. It's important to identify these people. Important that thyroxine is not used for anything other than hypothyroid conditions, and to then suggest that that person goes back to their general practitioner with a view to teetering them slowly off that dose. Once again, you never advise the person to stop taking it. Now, you might identify people who have not had a diagnosis of hypothyroidism because some of the diagnostic investigations have such narrow margins. There are some people who might have borderline but normal levels of T3 and normal levels of T4. But because T3 is the more active of the two hormones, in these people they may have high levels of an inhibitor of T3 called reverse T3, and it's just another metabolite of T3. T4 is metabolized to T3, and T3 is metabolized by deiodinase from T4, and it is an almost exact image of T3. It will affect the receptor for T3, but it has absolutely no potency at that receptor, so you would recognize reverse T3 then as a competitive inhibitor. So in those people that do have borderline levels of T3 and still are showing some symptoms, many naturopaths are recommending them to doctors who will measure reverse T3, where they may give slow release formulations of T3 to try and affect this reverse T3 dominance. Many medical practitioners will dispute the existence of this reverse T3 dominance, but many naturopaths and other natural healers will see it quite commonly in their clinical experience. So then to look at hyperthyroidism. In a similar way, we would look first of all at the goals of therapy, then look at the Western pharmaceutical treatments for it. Because these people have an excess of endogenous T4 and T3, the aim would be to decrease thyroid hormone overproduction and then perhaps to block the peripheral effects of excess T3 and T4 in that person. Because the person is hyperthyroid, first of all, they have to be brought back to normal physiological homeostatic ranges. A term that's used, they need to be euthyroid, so a well-functioning thyroid instead of an over-functioning thyroid. So what is used are various antithyroid drugs. We'll look at some examples of these antithyroid drugs. They're called the thyroid block. After that block, you then use hormone replacement for life. So it's block and replace therapy. It's important here then that there is once again constant monitoring of the levels of thyroxine to make sure that block and replace therapy is appropriate. Also, if the person had a definitive treatment, surgery or radioactive iodine to block certain functions of certain parts of a person's thyroid, that then they are monitored to see that they have now come back to normal T4 levels and that there is constant monitoring of their thyroid, that they are maintaining that euthyroid state and perhaps not going into hypothyroidism, where they will then need to go on to perhaps hormone replacement therapy for life of a T4 thyroxine. So first of all, the block drugs. They are drugs such as carbamazole, which is sold under the brand name neomycazole, and propylthiouracil. These drugs inhibit thyroxine synthesis, They might also inhibit iodination of tyrosine, so that some part of that metabolic pathway leading to thyroxine is inhibited. These block drugs, the antithyroid drugs, produce some gastrointestinal adverse effects and some CNS effects, but it's important to note one of the more important adverse drug reactions is that bone marrow depression and hematological disturbances. Also, in very high doses of these antithyroid drugs, the person might develop hypothyroidism if they had taken too many. These antithyroid drugs interact with many other medications. We've mentioned some of the commoner ones. Lithium, warfarin and digoxin interact with a wide variety of other medications. And iodine can have many effects on the thyroid depending upon dose. It can lead to increased thyroid activity, but as we'll see shortly, depends upon the dose. Iodine can also feed back negatively onto the thyroid and suppress its function. So these antithyroid drugs might be interacting with iodine. You would then guess from the warnings and contraindications, they are used with caution in anybody that already has a low leukocyte count because they will cause further bone marrow depression. There are some people who show a hypersensitivity to sulfur-containing drugs. Carbamazole and propylthiouracil will also show the same sort of hypersensitivity, and if the person was hypersensitive to something, say trimethoprim sulfamethoxazole, an antibiotic, might be used with caution or avoided in such a person. And similarly, if a person had liver impairment, because the antithyroid drugs are metabolized in the liver, they would be used with caution or avoided if possible. As these drugs are antithyroid and inhibit the normal metabolic pathways leading to thyroxine production, they will do the same in the fetus, so they are actually contraindicated in a person who is pregnant. There are other medications for hypothyroidism that you may see in use. First of all, we mentioned iodine and iodides. Here, the person might be about to have surgery to remove some of their thyroid tissue, or perhaps a carcinoma, or they may be about to receive radiation. You want to reduce the vascularity and size of the thyroid in the meantime, so an excess amount of iodides might be given. In Lugol's it's actually iodine, but if it's an iodide preparation, the iodide is physiologically converted to iodine in the thyroid before it then goes through those iodination reactions to make T1, T2, T3 and T4. In high doses though, the iodine can be suppressive on the thyroid and suppress its function, and so what used to be quite an enlarged gland can become smaller under the effect of this iodine. It's as if before it was goitrous and now its size has been reduced, ready for the radiation or ready for the surgery. Similarly, radioactive iodine might be used in hyperthyroid conditions. We already saw that it might be used to render a person more euthyroid. But it might also be used in thyroid carcinoma. Any of these iodine or iodide solutions tend to concentrate that particular mineral, that non-metal mineral in the thyroid, and if it's radioactive 131 iodine that becomes localized in the thyroid, that's where the beta particles will be released the most, and those beta particles are ionizing radiation that will damage that thyroid tissue. Furthermore, this radioactive iodine might be used as a diagnostic. It might be used in thyroid function testing, where after taking a very small dose of the radioactive iodine, scintigraphy is used to see where that radioactive tracer has concentrated itself, usually in the thyroid, and it will show up any goitrous areas as hot spots, any over-metabolic areas as hot spots, and so on in that person's image of their thyroid activity. Now, one last drug class that you'll see used in hyperthyroidism are the beta-adrenoreceptor antagonists. Remember those? They were known quite commonly as the beta blockers. These are not used to treat the person's cause of their hyperthyroidism. This merely treats the symptoms. T4 and T3 can act at adrenoreceptors and can mediate a faster heart rate. You'll also recognise that it is the sympathetic nervous system that leads to sweating. So these beta blockers are being used to treat the effects of the person's hyperthyroidism. The tachycardia, the tremor, and the sweating, they will block all of those symptoms, but it is merely symptom control and not treating the cause. Then to consider the endocrine pancreas. We're particularly interested in the beta islet cells of the pancreas, the ones that produce insulin. Read up on the different classifications of diabetes. In type 2 diabetes, we're assuming the person has some normal insulin production. They may show insulin resistance in the tissues. And with time, people with type 2 diabetes drop off in the levels of insulin that their beta islet cells can produce, eventually to the stage where they may need insulin. So an old-fashioned term for it was non-insulin dependent diabetes mellitus, or NIDM, which you can use so long as you recall that towards the end stage complications of type 2 diabetes, if the person hasn't got under some sort of glycemic control, they may then progress to needing insulin. So type 1 is where the person, due to autoimmune destruction of their beta islet cells, produces no insulin and needs to therefore take hormone replacement therapy for life. They need to take insulin subcutaneously by injection. So there is also various secondary disorders. There is also a mature onset type diabetes which occurs in the young, MODY, and a range of other type 3 disorders. It might actually be a disorder in the pancreas that then leads to pancreatitis and damage to those beta cells and so on, leading to a diabetes. Then type 4 is gestational diabetes, where we'll see that the drug of choice is insulin. Diabetes mellitus is therefore a metabolic disorder in the endocrine system. There are many causes. It is a disease that has a very high morbidity and mortality burden. We'll see that it is a myocardial infarct that kills most people with diabetes mellitus. There are many complications, and we will only be able to talk briefly about some of those. These complications result from poor glycemic control. It is important that the person, if they are on one of these hormone replacement therapies, they're on it for life and it's to save their life. They should not be talked out of taking their Western pharmaceutical treatment. Natural therapists can assist more with the management, exercise, dietary, and other lifestyle management techniques that these people with diabetes mellitus must undergo to help achieve that control over their metabolic disorder. So normally, due to the actions of alpha and beta cells in the pancreas, blood glucose levels is also very tightly regulated by homeostatic controls to a range of something like 3.5 to 6.5 millimoles per litre. But everybody gets a spike in their glucose levels just after they've taken in food. That's normal hypoglycemia, but it is also normal for it to be transient and for those levels to come back down to the normal ranges a few hours after eating due to the actions of insulin. It's the liver that is particularly important for reducing blood glucose levels a few hours after a meal, because the liver is storing that glucose as glycogen in response to that hormone insulin. In response to another hormone released from the alpha islet cells of the pancreas, the liver then releases that glucose slowly back to the blood between the meals, so that there is always a controlled level of glucose in the blood available for the brain, and the brain must have glucose preferably as its fuel source. A lot of the glucose from the blood is taken up by skeletal muscle cells via a GLUT4 receptor. So skeletal muscle cells must uptake glucose in response to insulin. There are some tissues that, even when blood glucose levels are quite high, can uptake glucose without the need for insulin, but generally tissues prefer to have insulin first before facilitated diffusion of glucose into their cells is possible, because insulin opens up the receptor. So in skeletal muscle, insulin attaches to its receptor, its cells sends a signal, similar as we were seeing to those G protein coupled receptor signals that travel through membranes. This one affects the GLUT4 receptor for glucose and opens it up so that glucose can then diffuse into the cell. So insulin is affecting not only liver tissue to uptake glucose, it's also signaling adipose tissue to take up fatty acids that might be produced in the liver from excess glucose. They can also uptake glucose directly in response to insulin. And this will lead to more fuel storage, anabolic pathways. So alpha pancreatic cells released glucagon, and glucagon is very opposite in many effects to insulin. For example, glucagon tends to encourage all of the catabolic pathways. There is one, though, gluconeogenesis, which is activated by glucagon and inhibited by insulin. But once again, insulin always opposes the effects of glucagon. So here's a summary of some of those hormones. In addition, some pituitary hormones and adrenal hormones that likewise also affect carbohydrate, protein, and lipid metabolism. Here's the diagram of how after a meal, everybody's blood glucose levels go high. Everybody gets a transient hypoglycemia after they've eaten, but then normally those levels fall away to within normal ranges. Even after that meal, there is still some insulin being released from the liver in response to glucagon, and then after a meal, the levels will rise again. If a person goes into hypoglycemia, then their blood levels of glucose fall away to below normal levels. If they have hyperglycemia, even after eating, blood glucose levels will remain high. They will never fall back to normal homeostatic ranges. That might be because they don't produce insulin, or they produce insulin but their body cells are sluggish and resistant to the effects of insulin, and glucose is not properly absorbed. If it is normal homeostatic ranges, the liver is uptaking that glucose and, as we said, storing it as glycogen. Insulin tends to encourage pathways that will lead to storage of fuels. So some of that glucose might also end up stored as fat, and it is possible that there will be increased storage through protein. As blood glucose levels then drop and lead to a hypoglycemia, normally what would happen then to oppose that and to then eventually raise blood glucose levels again is two responses. First of all, it could be the sympathetic nervous system through the hormone adrenaline that might lead to a sudden release of some of that stored glucose in the liver. So if suddenly the roof fell in where you're sitting there reading the computer, there would be a sudden release of adrenaline from your adrenal cortex, and one of the effects it would have on your liver is to lead to a sudden burst of glucose available for you to use in your brain to process what actions you would take, whether that might be fight or flight, but you need glucose to do that fight or flight. Also, in hypoglycemia, we said the alpha cells of the pancreas will release glucagon. Glucagon will affect the liver and cause it to take non-carbohydrate sources, amino acids, or perhaps some of the products from the breakdown of fats, the glycerol, and use them to manufacture glucose. Put that out in the blood so that the brain then has the glucose that it needs. In hypoglycemia, that is also detected by the anterior pituitary gland. The adrenal cortex is then encouraged to release hydrocortisone, and hydrocortisone will raise blood glucose levels. In addition, the pituitary gland releases growth hormone when a person is hypoglycemic. Growth hormone, through insulin-like growth factor, then causes glucose levels to likewise go up. So in a non-diabetic patient, it is your normal insulin levels that control blood glucose levels. In a diabetic patient, there might have been total or partial destruction of their beta cells. If it's type 1 diabetes, there's been impaired insulin secretion or insulin production, and it tends to be total. This is an autoimmune phenomenon where the person is setting up a T cell response in their beta islet cells so as to wipe those beta islet cells out, treating them as if they are a foreign antigen. There is some genetics to the type 1 diabetes, but it's more in that receptor for the suppressor T cell system and various other protein receptors and genes controlling those. Then of course there are some lifestyle factors that impact and other important environmental factors that determine if that person will go on to develop type 1 diabetes. It's not just the genetics. If the person has functioning beta cells, they are producing enough insulin, but there's an inability of the body to respond to that insulin. That's a relative deficiency of insulin, and so this is termed type 2 diabetes. With time, as we said, eventually those people with type 2 diabetes might then secrete less and less amounts of insulin, and with time may stop insulin production and will need to then take hormone replacement therapy. So that resistance to the effects of insulin is what you see when the person makes sufficient amounts, but the target tissues just don't respond by uptaking the glucose as they normally would. A person with diabetes, whatever the cause, type 1, 2, 3 or 4, will show polydipsia, polyuria and polyphagia, the 3 polys. So they will be continually thirsty, they will drink large amounts of fluid, they will then produce regular daily urines, they will produce urine quite commonly at night, nocturia. Because they cannot utilize carbohydrates for normal energy, that's not their normal fuel, they will utilize their body fat instead. They tend to always be hungry, so that they're always intaking any sort of fuel, hopefully more lipids and proteins that the body can then use for its main fuel source. Remember, the brain must have glucose, so it may be using those other food types as a way of then making the glucose in the liver that the brain will need. Because they tend to use their fatty acids for their normal fuel, as per normal fatty acid metabolism, they will produce high levels of acetyl-CoA. This acetyl-CoA is converted into 3 ketone bodies. Review those ketone bodies. The normal metabolic process for their production is called ketogenesis. But in people who have type 1 diabetes, we'll see that they are prone to going into a disorder, ketosis. Because 2 of those ketone bodies are acids, high levels of those ketone bodies in the blood is also known as ketoacidosis. They can go into a metabolic coma when they have high levels of these ketone bodies in their blood. This coma could then be a cause of their mortality. So we said that diabetes, particularly diabetes type 1, has a high mortality associated with it. Nowadays, through first aid, people are aware of hyper and hypoglycemic comas. You would know for any person in a coma to give nil by mouth. If the person was still showing some signs of consciousness, they would have a swallow reflex and you would give them sugar. If it was a hypoglycemic coma, that might be enough to then raise their blood glucose levels and might bring them out of the effects of that unconsciousness and prevent the coma. If it's a hypoglycemic coma, the little bit of extra sugar that you give them and that they swallow will be fine. We'll see that in addition to these metabolic crises, such as the metabolic acidosis, there is also some very chronic long-term effects of having high levels of blood glucose. The person gets recurrent infections from the number of glucose in their tissues. Their sores heal so slowly. It produces many chronic effects in the tissues, and we'll see that these effects are either at the microangiopathy level or macroangiopathy level, at the level of small blood vessels and large blood vessels, both arteries and veins. So this is life-saving Western pharmaceutical therapy, but it does require that the person is very well committed to some important lifestyle changes and lifestyle long-term management of their metabolic disorder. If it's a person with non-insulin dependent diabetes, they might be on oral hypoglycemic drugs to bring down their blood glucose levels. But for them, the non-pharmacological regimens are very, very important. For a person with type 2 diabetes, if they don't heed the need to manage their diet, their exercise, and so on, then they may progress, as we said, to the need for insulin. In addition then to diet and exercise, there needs to be regular patient education about, as we'll see, some of the ways of monitoring their glycemic control, then to self-monitor with measuring glucose levels themselves or monitoring their insulin levels. Very, very important will be good foot care. We'll see that the person is at risk of losing their extremities due to gangrene and then the need to amputate to prevent septicemia and other ongoing complications. And so if regular foot care is implemented over the decades, this can save the person's extremities and their digits. So insulin is the cornerstone of treatment in type 1 and in type 2 diabetes, where it has progressed to the person not making any of their own insulin. So type 1 with that absolute lack of insulin, needing then hormone replacement therapy for life to keep that person alive. As we said, an adjunct in type 2, and the treatment of choice for a person who is pregnant and has developed gestational diabetes, being a hormone and also being the human recombinant form of insulin that's used these days, it's reasonably safe for the fetus. Originally, it was animal insulin types that were being used, either bovine or porcine sources from the abattoirs were used to make large amounts of insulin, and so many people developed hypersensitivity reactions or insulin allergy because it was from another animal and it was seen as a foreign antigen. So now with recombinant DNA techniques, we've taken out the gene for human insulin and used yeast or E. coli to make it in very large numbers. If people have a hypersensitivity, it's because they have a known hypersensitivity to yeast or some of the other nutrients that might have been used in the medium for the growth of the E. coli. But it has removed that insulin allergy. For some people, though, they may need to still access the animal sources. They are still available. Insulin is given subcutaneously. Depending upon the person's needs and circumstances, there are many formulations, different in the rate at which they deliver that insulin then to the systemic circulation. There are ultra-rapid acting formulations that will deliver insulin in physiological doses within 10 to 15 minutes. You could take this before a meal and there would be sufficient insulin there to deal with the hypoglycemia that's always seen postprandial after eating. Because of its short duration of action, though, it would need to be taken quite regularly with meals. But it does reduce the incidence of hypoglycemia. Then there's short-acting formulations which have an onset of action delivering physiological doses within half an hour to an hour after injection. They will continue to exert their effects for up to 8 hours, but sometimes the person can have taken too much for the amount that they have eaten, and so hypoglycemia does sometimes result. If the person was in a ketoacidotic coma, indicating that they were out of glycemic control, then it might be given intravenously in that emergency case, because ketoacidosis, as we said, can lead to coma and death. Intermediate acting formulations of insulin have an onset after about 1 to 2 hours, but the duration of action can extend for up to 24 hours. So for people who, for whatever reason, cannot take regular subcutaneous injections, will only need that one injection. Once again, it might be an inappropriate level of insulin for their actual intake of food, and hypoglycemia might be common. With the long-acting formulations, the very slow onset, it might be 2 to 4 hours before they have their action, but it could have a prolonged action for up to 36 hours. Oftentimes, that just provides a basal amount of insulin, and the person then still tops up with a rapid, short, or intermediate acting insulin dose before their meals. So combinations of these are quite common. We might have a combination of a short and an intermediate acting insulin. If it's a Humulin 30/70, we have 30% of a short acting insulin formulation and a 70% intermediate acting insulin formulation, so as to get the right levels of insulin and therefore prevent those hypoglycemic comas. So let's have a look at this adverse drug effect of insulin. It is that hypoglycemia. It assumes that the person has taken a dose of insulin and it is too high. They, though, have not monitored their food intake. Meals might have been skipped or delayed, or they might not have had enough carbohydrate in that meal, or they may have simply exercised too much, so that their levels of insulin while too high led too rapidly to a hypoglycemia. As we said, you give glucose while the person is still showing some symptoms of consciousness. They may just have a racing heart that they tell you about, or palpitations. You may notice that they sweat or have pallor. Might be a simple observation as they describe their hunger, and you know that they're diabetic, and then can alert them to perhaps taking a quick absorbable glucose source. They may tremble. They may be irritable and nervous. At this stage, it may require a first aider, a second person, to obtain a rapid source of glucose for them. Once again, the aim being that they have taken some insulin, you assume that they have, and that they've perhaps taken too much, and you're giving them some glucose that will bring their blood glucose levels immediately back up. All of these symptoms of tachycardia, palpitations, sweating, pallor, hunger, trembling, irritability and nervousness should remind you of the effects of adrenaline, and the person in this hypoglycemic state is producing that adrenaline as a normal hypothalamic response. They can try to stay as calm as they can, but this is the hypothalamic pituitary adrenal axis producing this adrenaline for them. They will also perhaps give you a few other clues. They may have difficulty concentrating, they may have mental confusion, might just mention a headache, or they may say that their vision has blurred. They may have a double vision. The person might start speaking incoherently or show temper tantrums, aggressiveness, or drowsiness, some sign that their levels of consciousness are changing. While showing any of those symptoms, once again, you can give an immediate source of glucose, such as jelly beans, something with sucrose in it that will rapidly raise their blood glucose levels. If the person is unconscious or in a coma, you don't give anything by mouth because it could wind up in their lungs. They don't have a swallow reflex. The unconsciousness and coma is related to that low glucose levels. The brain must have glucose for its proper functioning. Insulin itself has many other adverse effects. We saw insulin allergy. It's rare, and as we said, it's more to the impurities in that growth medium that was used with yeast or E. coli to grow up large levels of human insulin. At the site where the person injects, normal lipid distribution might be altered. They might show a lipodystrophy. Also, there may be a transient edema that occurs just after hypoglycemic attacks, and it will remit spontaneously the moment that person comes back into glycemic control. There are many drugs that through their interactions might impair glucose control, and so if a person is on glucocorticosteroids, beta blockers, thiazide diuretics, phenytoin, an anti-epileptic medication, they may show changes in glucose control, and this may require dosage adjustments of either the interacting drug or their insulin. So we said in hypoglycemia, give something sweet. Biscuits, a lolly, a sugar, jam, anything that has that burst of glucose in it, and if that person appears conscious. If they're unconscious, you can try rubbing honey under the tongue, onto the mucous membranes. Even a syrup from cane sugar or corn syrup will release some glucose. You don't give chocolate. It doesn't have high enough sugar levels anyway, and it also has a very high fat content, which is not what's going to reverse their hypoglycemic coma, so it's not very suitable. If the person was in a hyper state, then that small amount of glucose that you give would not make any difference to their hypoglycemic coma, and any changes that it would incur are not as severe as that person's existing hypoglycemic coma would cause. So for a person who is on oral hypoglycemic agents, these are people that have type 2 diabetes. In addition to taking an oral hypoglycemic, they should be on lifestyle management and exercise and a dietary control program. The oral hypoglycemics do depend upon the person having some residual insulin that will then also help with the clearance of the glucose from that person's blood. So they're an adjunct to that normal lifestyle change. The oral hypoglycemics either stimulate the pancreas to release more insulin, or they may affect the cells of the body and lower insulin resistance, make those cells more responsive to the effects of insulin at uptaking blood glucose. They might sensitize cells to the actions of insulin, so they thereby reduce the glucose load. They might also then inhibit gluconeogenesis that would put even more glucose back out into the blood. Some of these oral hypoglycemic agents also have an effect on levels of carbohydrate that are absorbed from the diet. There are many types of oral hypoglycemics. We've looked at all stages of carbohydrate digestion, absorption, and then uptake into the cells, and looked at some example agents such as acarbose and where it blocks at digestion, the glitazones and metformin, which affect absorption, repaglinide, which stimulates insulin release from the pancreas, and various glitazones and metformin that also stimulate glucose uptake and any process that stores glucose encouraged by the glitazones and metformin. So let's have a look at some of the examples of oral hypoglycemics. The sulfonylureas are oral hypoglycemic agents, including glibenclamide and gliclazide. Glibenclamide, sold under the brand name Daonil, and gliclazide, Diamicron. We'll look at glibenclamide as the prototype for this type of oral hypoglycemic, and if a person has uncomplicated type 2 diabetes, so there is still some insulin production, glibenclamide will encourage more insulin and increases cellular sensitivity to that insulin, thereby decreasing insulin resistance. So note we said that the type 2 agents always assume that there is still some insulin production, so it's still as yet an uncomplicated type 2 diabetes. The adverse effects to glibenclamide include hypoglycemia, that they may over-exaggerate their action. We'll see one problem with these oral hypoglycemics is the weight gain that some people then show, and then as usual gastrointestinal disturbances and hypersensitivities such as a rash. Glibenclamide is used with caution in the elderly or people who have hepatic and renal impairment. You also avoid them in people who may have a high fever, an infection, or a severe liver impairment. As we said, the drug of choice in pregnancy is insulin, so oral hypoglycemics would be contraindicated in a person who is pregnant or lactating. So then we'll look at metformin as the prototype of the biguanide oral hypoglycemics. Metformin sold under the brand name glucophage. It's indicated in type 2 diabetes, where it's usually the first-line therapy, and some of the other sulfonylureas or glitazones might only be used if the person was not responsive to metformin. Metformin, likewise, increases insulin sensitivity. Glucose is taken up by muscles. The liver is inhibited from releasing glucose from its stores, and so metformin is said to be anti-hypoglycemic rather than being a hypoglycemic agent. But it will show a synergistic action when it's taken with sulfonylureas. There will be a synergistic hypoglycemia. It's very effective in people who are obese because metformin does not cause that weight gain that we saw with the sulfonylureas. In the elderly, when put on metformin, the person tends not to show that hypoglycemic reaction when that metformin is used alone. Metformin shows various adverse drug reactions and warnings. It has limited use in people who have renal or hepatic impairment, and a person that has a history of alcohol abuse or a history of metabolic acidosis. Metformin is also used with caution. People who have type 2 diabetes tend to show less of that metabolic acidosis than people who have type 1, but if the person has this history, then metformin might not be the drug to use as the first-line therapy. The most serious of its adverse drug reactions is lactic acidosis. This is where the person accumulates metformin, and if a person is elderly or is at risk of this acidosis, then they might show this adverse effect. Metformin interacts with beta blockers, cimetidine, calcium channel blockers, digoxin, and morphine. It's contraindicated in people with liver or kidney disease or any cardiac disorder, severe burns, dehydration, or very serious infections. So you saw previously with the sulfonylureas the same sort of problems, that if the person is showing a fever and so on, that it's used with caution or avoided, and the same thing here with metformin. So the other oral hypoglycemic agents that we showed you on the chart, acarbose, which is sold under the brand name Glucobay. Acarbose is actually a carbohydrate, an alpha-glucosidase enzyme inhibitor. It reduces the absorption of starch and disaccharides. It does have adverse drug reactions in the gut, but these are reduced if the person takes a diet that's less in sucrose, so often very advantageous for them anyway. So its efficacy is as a second-line adjunctive agent if needed to help control the person's hypoglycemia and to get them into glycemic control. Then there are the glitazones. Another name for the glitazones, thiazolidine diones. So you'll see a common generic ending. They will have azone, or they might have litazone in the name to tell you they're of this chemical class. Pioglitazone is sold under the brand name Actos. It decreases insulin resistance at the liver cells, skeletal muscle cells, and adipose tissue. For example, in the liver, it inhibits gluconeogenesis. These glitazones are very effective as a third-line therapy for a person who's unresponsive to metformin and sulfonylureas. This requires an authority script. Adverse effects of these glitazones, they'll cause edema and hepatic effects. So if a person has some sort of liver dysfunction, they would be used with great caution, but for anyone on these glitazones, you would monitor their liver function tests. Like the sulfonylureas, these glitazones lead to weight gain as an adverse drug effect. So it was only metformin that could be used with obese clients who have diabetes type 2. Repaglinide is sold under the brand name Novonorm. This particular oral hypoglycemic stimulates the beta cells of the pancreas to produce more insulin, and so it improves the secretion of that insulin whenever there are high glucose levels around. It improves the signaling effects. So it has an action similar to the sulfonylureas. Adverse effects, it can over-exaggerate its effects, it can produce a hypoglycemia, and repaglinide can also have gastrointestinal disturbances. So warnings and contraindications, used with caution in people who have a liver impairment. Corticosteroids are another class of drugs that are used in